This is a patient of a CA esophagus where we will be doing a laparoscopic thoracoscopic esophagogastrectomy. First step is after putting the ports. There are 5 ports in the abdomen. We go ahead and mobilize the stomach close to the spleen and the colon in order to harvest as much lymph nodes as possible towards the fundic region at the splenic artery area. And now one can notice that the harmonic is working very close to the spleen and the splenic vessels, and this is the way the left crust is completely denuded of, and all the lymphatics and other retroperitoneal tissues are taken up. Here one can see that there is an incision being made in the superior border of the pancreas, and the lymph nodes are gradually being harvested, skeletonizing completely the splenic artery. Here the left gastric vein is gradually coming into view, and this has to be taken, and after a proper right angle maneuver and isolating the vein, one can take a clip and or one can use an energy device like M.Ch, which does not vibrate, and the vein can be taken. After this, gradually above the pancreas up to the left crust, around the left border of the aorta, the dissection proceeds, which completely bears the left crust, and this is the dissection which ultimately culminates into a left gastric artery skeletonization, which is secured by suture, clip, and taken with the M.Ch device. Then the right side of the lymphadenectomy is being done. You can see that the right crust is getting completely denuded, and now the pars flaccida is opened up, and the sampling of the hepatic lymph nodes are done. This is followed by continuous mobilization at that particular plane towards the hiatus, and one can see that with being very close to the hiatal muscles, the dissection is being proceeded so as to harvest maximum amount of lymph nodes and the periesophageal tissue, because the tumor is close there. One should keep on working exactly at the subpericardial fat. Dissection in the abdomen, through abdomen, can be done very high, and on both sides the pleura gets visualized, and lots of lymph nodes are harvested thus. This is followed by then a marking of the area of the Laparoscopic of the stomach where the conduit is going to be made from the third branch of the gastric vessels, and this should be followed by proper mobilization towards the pylorus, as it is in this particular step can be done early also, but sometimes when we keep on doing the pyloroplasty, this mobilization is done. Now one can see that one does a Hennig Miculis single layer pyloroplasty, and serially staplers are applied from the Laparoscopic up to the fundus. That should be almost 4 centimeter of the fundus is taken, and serially applying the staplers. This is followed by a pharyngectomy, which is raised for the first 20 centimeter of the duodenojejunal flexure. A Follis catheter is placed, a purse string was applied before, and a stam method of pharyngectomy was done, which the loop being fixed on all sides in the peritoneal cavity. This step may be difficult, and a T-fastener may be used, or the ports may be repositioned. After this, the thoracoscopy is proceeded. One can see the azygous vein in view, and one can see the abdominal incisions, which is almost up to the azygous vein. This is followed by a proper complete clearance of the mediastinum on both sides of the esophagus, and this lymph node clearance, almost half or more have been already done from below, so this is not a very big deal here. The whole of the pericardium is completely bared, the esophagus is completely bared, the site of transaction is marked, and the lower part of the esophagus is tied, and the esophagus is transected exactly above the level where a tie is made. This is infraazygous because the tumor is small, preoperatively radiated, and just above the G junction. After this, the whole specimen is brought up. One can see that the gastric tube is nicely brought up. The last part of the gastric tube, which was not transected by the stapler, is now being clipped and cut. This can be again used as a stapler, but here we just saved some stapler. After this, the specimen was put through the hiatus down into the abdomen. After this, an hand-sewn end to side conduit of the stomach and the esophagus, esophageal anastomosis are made. This is made by completely hand-sewn technique. First few stitches are taken to stabilize the esophageal wall with the ceromuscular of the stomach. After this, a gastrotomy was done, and the anastomosis is very carefully fashioned. Hand-sewn anastomosis at this particular stage ensures a proper mucosa-mucosa union, and the space though appears to be narrow, but it's pretty ergonomically suitable anastomosis. So posterior continuous and anterior interrupted anastomosis are planned, and gradually from the other end down towards the end of the surgeon, that means from the left side of the patient to the right side of the patient, the anastomosis proceeds. The continuous full thickness esophagogastric anastomosis, as it is very clearly seen here. At the angle, the conal stitches are used in order to invert the edges of the stomach and the esophagus both, so that no mucosa comes out, and the suture is tied there. After this, the Ryle's tube is being passed through from the mouth, from the nose to the pharynx, through the esophagus into the stomach conduit. And after this, again, one can see the esophagogastric anastomosis anterior layer is completed. Here we have used an anterior continuous layer also, because one can see very easily how nicely ergonomically it is coming close. That's the way the esophagogastrostomy is performed, and a few stitches are put with the ceromuscular of the stomach and the anterior mucosa, anterior muscle of the esophagus in order to stabilize. Chest tube inserted. Thank you. In the abdomen, then we go ahead and we remove the specimen.